All right. Hello, everyone. My name is Maya Schonbach, and I am a clinical psychologist in training. And I wanted to welcome you all to our webinar today about trichotillomania, about habits, compulsions, addictions. Let's try and uncover this whole thing together. And I wanted to encourage you guys to ask questions throughout the presentation, write them into the chat, and then at the end of the presentation, I'll do a Q&A and we'll go through all the questions together. And also, I really want to suggest that you guys stick around until the end because I'll have a promo code at the end of the webinar for a discount on subscribing for the first month to our program. So definitely stick around for that. Let's get started. Okay, so just a quick outline. So first we'll talk about differentiating between goals, habits. I'll talk a little bit about addiction and compulsion at the beginning, but we'll talk more deeply about whether trichotillomania is just a bad habit. Is it a lack of impulse control? Is it considered an addiction? We'll do a conclusion and then a Q&A, like I said. So I like to start off with a quote. So this is from William James, and he's really one of the great philosophers and psychologists of all time. Some people consider him to be the father of American psychology. So way back in 1890, he actually wrote, "When we look at living creatures from an outward point of view, one of the first things that strikes us is that they're bundles of habits. The more of the details of our daily life that we can hand over to the effortless custody of automatism, the more our higher powers of mind will be set free for their own proper work." So I think that this is a really cool quote to think about the idea that, first of all, us as humans, we're living creatures, but all living creatures have habitual behaviors. And the idea that habits and habitual behaviors are things that are helpful to us and things that us as living creatures are natural, because what it does is it allows us to have higher powers of mind, like our cognitive resources, things like decision making, problem solving, attention, having that freed up for proper work, for more important things, for things that we want to do and things that we want to dedicate our higher resources, our higher cognitive resources towards. So I thought this was pretty cool that he also wrote this all the way back in the 1800s. So think of it. Okay, so let's start. We're going to talk about goals, habits, addictions, compulsions. Oh my, so many things. Kind of feels like a mess, like they're all intertwined. What does this mean? What's the difference? Let's work through these together. Okay, so goal-directed behavior versus habitual behaviors. Let's break those two down. So first, goal-directed behavior, it's an action that's done deliberately in order to achieve a specific result. So first of all, it involves thinking about the future, about your future consequences, and it's adaptable to change. So for example, goal-directed behavior. So maybe you're studying for an exam and you want to get a good grade. So you actively decide to study because you want the reward of a high grade. So we use that's the goal-directed behavior. And then we use the word habit to describe actions that we do automatically without thinking about the outcome, without thinking about the result. So habits are driven by triggers, and triggers can be emotions also. And habits are automatic and they're inflexible. And habits are efficient, meaning, like William James wrote, that they free up your attention, your decision-making skills, but they're not easily changed. So think about how many of us have tried to break a habit. It's hard. And remember, just comparing these back to goal-directed behavior, they're more flexible, but they also require more thought. So an example, maybe we think about biting your nails when you're stressed. So you do it automatically without thinking about the outcome. So you're triggered to do it, the behavior, because you're from the emotion of feeling stressed, you start biting your nails. But you're not thinking about the outcome. It's on a goal-directed behavior. You're thinking, it happens automatically. And then the extreme version of habitual behavior is when they turn into compulsions or addictions. We'll talk about that in a little bit. So again, the key difference between goal-directed and habitual behaviors is if the behavior changes according to whether the outcome is desirable or not. Okay? So in goal-directed behavior, again, if the outcome is no longer desired, then you stop the behavior. So say for the studying, if you're studying more and more, but your grades aren't getting any better, so say you're doing practice tests and you're seeing my practice tests aren't getting any better, I'm doing well, I'm getting 90s, I might decide to stop studying. And then for habitual behavior, the behavior continues even if the outcome is no longer desired. So again, because the action is triggered by a cue or things like an emotion, not by the outcome itself. So like we said with the nail biting, you could keep biting your nails even if it's not relieving stress anymore, because your brain automatically associates stress with biting your nails. So you're going to keep doing it even if the outcome isn't what you want. Okay, so let's look at another example. This is from a study done in 2019. And okay, so how they described it is that we have the stimulus of a bar sign. So a person sees a bar sign, they enter the bar, they order the glass of wine, that's the action or the response. Then they drink the wine, and the outcome is feeling good. The outcome is drinking the wine and feeling good and calm. Okay? So let's break this down. If it's a goal-directed action, the action is driven by the desired outcome. So the drinking the glass of wine and feeling good and calm. So if the outcome becomes less valuable or it's less desirable, so for example, say you become drunk, then the person is less likely to order the wine because you're not getting this feeling of good and calm. You might feel sick. So you're going to stop ordering. Versus if it's a habitual response, this is triggered by a cue. So for example, seeing the bar sign. You see the bar sign, without thinking about the outcome, without thinking about drinking and feeling good and calm, the person enters the bar, orders a glass of wine, even if they don't really want it anymore, even if they're already drunk and they feel sick, they're going to keep doing it because it's an habitual response. Okay? Okay, so just again, we said that for habits, the behavior continues even if the outcome is no longer desirable because the action is triggered by cues or things like emotion, not by the outcome itself. But compulsions and addictions, these can be seen as extreme forms of habits. And what they involve is continuing to do something that used to make you feel good, even though it's causing you problems right now. So really, this key aspect of an addiction or a compulsion is that you continue to do the behavior, even when you know it's causing you harm right now. So here also from this paper, it's that you can see in this image is how compulsive or reward-seeking behaviors are actually implicated in a bunch of different mental health disorders. So things like substance addiction, binge eating, different types of behavioral addictions, things like gambling disorder, internet use, problematic internet use, shopping. So these are all instances of compulsive reward-seeking behaviors being implicated in mental health disorders. Okay. So from all of this, we can understand that trichotillomania, or hair pulling disorder, is not goal-directed behavior because it's not driven by a desired outcome. But is hair pulling just a bad habit then? So let's. Oh, when I saw the question in the Q&A about the audio, I'm really sorry. I don't have a way to fix the microphone. Sorry. But I'll talk closer. Okay, so let's talk about trichotillomania in the DSM-5, or the Diagnostic Statistical Manual, which is the book that we use as mental health professionals to diagnose mental health disorders. So first of all, the first criteria is there's recurrent hair pulling that results in hair loss. So number one, it causes damage, okay? Number two is that there's repeated attempts to decrease or to stop the hair pulling. So it requires you to try and stop the behavior. Then three, the hair pulling causes significant distress or impairment in social, occupational, or other important areas of function. So it causes you distress and dysfunction. And then you can't attribute the hair pulling to the psychological effects of a substance. So for example, cocaine or another medical condition that's also can have or something else. And then it can't be better explained by symptoms of another mental disorder. So a differential diagnosis. So things like delusions or hallucinations in a psychotic disorder, or from body dysmorphic disorder when it's to improve maybe some perceived flaw or perceived defect. It can't be from self-injury, for non-suicidal self-injury, self-harm. It can't be from that. These are all differential diagnoses. So is trichotillomania an example of bad habit? So it's kind of, I drew like a spectrum. So bad habits are considered bad because the behavior is undesirable and it's not good for your overall health. But when the impact of the habit causes significant dysfunction, it hinders your daily function, it causes you severe emotional distress, that's when you need to consider the presence of a clinical disorder, okay? So the diagnostic criteria, it clearly describes the inability to stop or to reduce the pulling behavior. And again, some people argue that all bad habits are difficult to stop, but really it's this combination of this with the functional impairment, with the emotional distress, that's really what separates habit from a disorder. Okay, that's the spectrum that I drew. I think that's like the key takeaway is to think about those aspects and then to consult a mental professional. Okay, so we can understand from all of this that hair pulling disorder is not goal-directed behavior, and it's also not just a bad habit. But is trichotillomania a lack of impulse control? Okay, so what is impulse control, first of all? So impulse control, it's the ability to resist an urge or delay an urge or drive or temptation. And it prevents you from performing an act that could be harmful to yourself or to others. And it involves being able to manage and to regulate your emotions and behaviors, and particularly in response to external stimuli, but also internal drives. And it happens in a way that aligns with long-term goals and societal norms. So let's look at the key aspects of resisting temptation. So first, you are able to refrain from engaging in behaviors that are immediately gratifying, but potentially harmful or counterproductive. To delay gratification. So you're able to postpone immediate rewards in order to achieve a more significant long-term outcome. So think about studying for a test. Maybe if somebody calls you, invites you to do something, you're going to say, no, I'm going to delay that gratification. I need to study for my long-term, my test for long-term reward. Emotion regulation. So managing your responses, to avoid impulsively reacting, that these can result from intense feelings like anger, frustration, but also excitement. Think about a little kid that isn't able to regulate their emotions, and they're so excited that they break their toy. And then cognitive control. So it involves higher order cognitive processes, things like planning, decision-making, problem solving. These are all to inhibit your impulsive actions. And think about what William James wrote, that the quote that I had at the beginning of the presentation, the idea that habits free up, or habitual behaviors free up all these cognitive resources. So we need these to inhibit our impulsive control. Or impulse. Okay, so why is impulse control important? So for your personal well-being, effective impulse control is associated with better mental and physical health outcomes, because it helps you avoid engaging in risky or engaging in self-destructive behaviors. Social functioning, so it helps promote social interactions and relationships, because it allows you to act in socially acceptable ways, and really to understand the consequences of your actions. So you're not going to go and, even though you're angry at someone, you're not going to go screaming at them, even though you may want to, because you understand the consequences of your actions. And think about things like empathy, so you can control your impulses. And then achieving goals. So again, talking about goal-directed behavior, persistence, having the ability to stay focused on a long-term objective despite having short-term temptations or distractions. So not stopping studying for the test, even though you may want to, I don't know, go out for dinner or go for ice cream, I don't know. You're going to continue doing it, studying for this long-term objective. Okay, so impulse control disorders. These are a group of behavioral conditions that really make it difficult to control your actions or your reactions. Typically, these behaviors cause harm to yourself or to others, and often they lead to issues with the law. So these are the main impulse control disorders. So kleptomania, it involves an irresistible urge to steal things that you don't need for your personal use or for monetary value. Pyromania, so it's this urge to start fires in order to relieve tension or for this sense of instant gratification. There's intermittent explosive disorder, so that involves recurrent episodes of aggressive outbursts that lead to assault, to destruction of property. And then finally, we have pathological gambling. So that's really this inability to resist the urge to gamble. And that has to lead to significant personal and financial consequences. Okay, so is trichotillomania an impulse control disorder? So both involve repetitive behaviors, and they cause significant distress and impaired functioning. And interestingly, a recent study talked about the differentiation between impulse control disorder and trichotillomania in 2024, a few months ago, came out. And they talk about the fact that they commonly coexist in the same person. And that actually really makes diagnosis and treatment more complicated. However, no, trichotillomania is not an impulse control disorder. It's actually categorized as an obsessive compulsive and related disorder in the DSM-5, in the Diagnostic Statistical Manual, the book that we use to diagnose mental health disorders. And so this recent study talked about how the idea that there's been a lot of research that shows that there's a lot of commonalities between trichotillomania and OCD. And that's why, so trichotillomania actually, before this version of the DSM, was actually in the category of impulse control disorders. And they moved it into the category of obsessive compulsive and related disorders. I saw a hand raise. I just want to remind people to write into the chat if they have any questions or comments. Okay, so in terms of symptomatology and behavior, so trichotillomania, again, it involves repetitive behaviors driven by urges, and it's similar to the behavior seen in OCD. So it's this compulsive nature of hair pulling and really this inability to resist the urge that it aligns it more closely with OCD-related behaviors than with impulse control disorders. In terms of cognitive and emotional patterns, so people with trichotillomania, they often experience an intense urge to pull the hair and engage like repetitively to alleviate tension or to achieve a sense of relief. And this pattern, it's similar to what the cognitive and emotional experience is seen in OCD. Again, in terms of treatment, so treatments that are effective for OCD, mainly CBT or cognitive behavioral therapy. And then also I'm saying this with an asterisk because there is no FDA approved medication specifically for trichotillomania, but there are some evidence that selective serotonin reuptake inhibitors or SSRIs that is have been found to be helpful for OCD, also helpful for trichotillomania. And so this therapeutic overlap suggests that trichotillomania is much more appropriately categorized with OCD and related disorders than impulse control disorders. And so really it's all of this underlying research that shows that there's this better similarity between trichotillomania and OCD that puts them under this kind of family of obsessive compulsive related disorders separately from impulse control disorders. Okay. So we understand so far that hair pulling is not goal-directed behavior. And it's also not just a bad habit because it needs to cause significant distress and functional impairment. But could hair pulling disorder or could trichotillomania be considered an addiction? So trichotillomania. Clients often describe the inability to stop pulling and this irresistible nature of the urge. They say it's similar to the feeling of an addiction. And they say, I just can't stop. I feel addicted to the pulling. And interestingly, about 25% of people with a BFRB or with a body-focused repetitive behavior also suffer from an addiction. And then again, I just want to say this number is actually likely higher because BFRBs and also addiction, there is a lot of shame and stigma surrounding them. So could even be higher than 25%. But this high comorbidity or the high coexistence of trichotillomania and addiction doesn't mean that it's an addiction because a lot of different factors play a role. So it's really important to understand the link, to understand the connection, the difference between addictions and trichotillomania or compulsive pulling. Okay, so let's talk first about the compulsive pulling cycle. This is how we typically like to conceptualize what happens to us when we want to pull, or in the pulling cycle. So typically, the cycle starts off with a trigger, and this trigger can vary from person to person. So a trigger could be typically stress, anxiety, boredom, that's a big one. It could be perceived imperfections in hair, maybe even a feeling, a physical sensation. This hair is thicker than the others, this hair is thinner, I'm going to pull it out. Okay, so following the trigger, there's a strong urge to pull the hair. And this is intense and it's hard to resist. And this urge could be driven by a desire for relief, a sense of gratification, need for control. Typically, it's talked about in terms of relieving these uncomfortable, distressing emotions, but it could be driven by other things as well. And then, despite the efforts to resist, You pull the hair, and the pulling could happen using tools with different things, but the pulling happens. And then initially, the act of pulling could provide a sense of relief or a sense of satisfaction, like we said. So it could temporarily alleviate the feelings of anxiety, of distress, of discomfort. And really, it's this temporary relief that actually reinforces the whole behavior and the whole cycle, and it strengthens this compulsion to pull in the future because it gives you a sense of relief. However, after the pulling episode subsides, come up the feelings of guilt, of shame, of embarrassment, and those often set in. And then why do we call this a cycle? Because those in of themselves, those uncomfortable emotions can then be triggers for the next cycle. And so you're stuck in this compulsive picking cycle. Okay, so let's now compare this to the addiction cycle. So it also starts off with a trigger. So again, stress, negative emotions, things like that can be a trigger for addiction, but also very commonly is environmental cues. So remember in the image with the bar and the ordering the alcohol, so seeing the bar sign, that's an environmental cue that could initiate the cycle. And then we call, instead of an urge, we call this a craving. So we have an intense desire for this addictive substance for the behavior. And then often, that something that goes along with the obtaining the substance or engaging in the behavior is a ritual or a specific routine or a habit. So it could be something like rolling a cigarette, or in the example with the bar, it could be maybe talking to the bartender, something like that. And then there's using. So it's consuming the substance, engaging in the behavior. And then after that subsides, there's feelings of regret and helplessness after the using, after the feeling of pleasure that subsides. And then again, those, like with the compulsive picking cycle, pulling cycle, sorry, here, these feelings can also become a trigger, and then it can get you stuck in the addictive cycle. Okay, so let's separate now pulling versus addiction. So the nature of the urge. So in addiction, it's driven by cravings and a desire for pleasure or for relief provided by the substance or the behavior. And then in compulsive pulling, it's typically driven by a need to reduce anxiety or distress, often from maybe from an intrusive thought or just a need to reduce this discomfort. And the focus of relief is different. So in addiction, you're focused on gaining a pleasure or a high from the substance or the behavior. And in compulsive pulling, it's focused on reducing anxiety or discomfort. Typically, that's the underlying purpose. And then behaviorally, so in addiction, it's often substances or behaviors that lead to the pleasure. And then in compulsion, like we said, the repetitive pulling is typically performed to relieve anxiety, not necessarily for pleasure. And then emotionally, here it's similar. It's guilt and despair in addiction, but it's after the pleasure fades. And then in compulsive pulling, it's guilt and shame from the inability to control the pulling and from the disruption that it causes to your life. And then in terms of insight and awareness, so in trichotillomania, people are often aware of the harm that's caused by their hair pulling, and they try to stop, right? It's one of the criteria, but they can't stop. So conversely, addicts typically are unaware of the harm that their actions are inflicting, and they really only recognize it after a significant amount of damage has occurred. There's often a lot of denial there. And then in terms of, as a result of this attempted behavior modification, so people with trichotillomania repeatedly try stop pulling their hair. It's a criteria for diagnosis. And again, showing that they're aware of the harmful nature of their behavior. And also, addicts may attempt to quit, but typically this only occurs after there is substantial damage. Again, there's less awareness of the problem severity while they are actively engaging in the addictive behavior. Okay, so I wanted to talk just a little bit more about addiction, just to say some things that typically a lot of us are addicted to. So it could be anywhere from alcohol, cigarettes, sugar, it's something that it's an addictive substance, caffeine, who among you feel an addiction to caffeine, need a coffee every day, prescription drugs, maybe illicit drugs, exercise. These are all examples of things that we can be addicted to. And so I kind of want to end this off with posing the question to you: where do you draw the line? So I think it's important to think about this for every single individual person. Where do you draw the line in terms of addiction? Is sugar, caffeine, are we addicted to that versus alcohol versus or drugs? And then I think if we want to tie it back to the quote at the beginning of the presentation, the idea that habitual behaviors are something that is important. It's innate in us as living creatures. We need this in order to free up our higher cognitive resources, our decision-making, our problem-solving abilities. We need to have these habitual behaviors in order to be able to think long-term, have goal-directed behaviors. But again, it's important for every single person to kind of think about where it's important for them, and what they consider for them to have an addiction versus not. Sugar, caffeine, again, I'm just putting those out there. So I'm kind of leaving this up to you as an open question. Again, in terms of the mental health field, the big difference is the idea of significant emotional distress and the idea of functional impairment or dysfunction, right? Those are the two key elements that take things to a disorder, right? So again, if you feel significant emotional distress or impairment in your life in different areas, then yeah, it's important to seek help from a mental health professional, and that maybe is where we should be drawing the line. But again, it's also individual, and I think it's important to think about that every person. So just a quick overview. We talked about today the definitions of goals, habits, addictions, compulsions. Is trichotillomania just a bad habit? No, it's not just a bad habit, because it has these additional components of the significant emotional distress, the severe dysfunctional impairment. Is it a lack of impulse control? Also no. We saw that in the recent update of the DSM-5, trichotillomania used to be an impulse control disorder, and actually due to a lot of research recently, it was shown that it's more similar to obsessive compulsive and related disorders, or OCD, and so it's under this family of disorders now. And is trichotillomania an addiction? So I said a lot of our clients kind of describe it, the feeling of an addiction, and we compared and contrasted the addictive, the cycles. It's not considered an addiction, but again, like I showed that sugar, caffeine, like how do we really define the addiction? I think that's also really important for every person to think about for themselves. And then I just wanted to touch on some of our free resources that we have at TrichStop. So monthly free webinars like this one, we have them every month, but also we have like Q&A sessions, we have mindfulness workshops, so definitely check those out. And we also have recordings of all of our webinars on our website, on our YouTube page, so look at those. And then on our website, trichstop.com, we have different forums and blogs, and you can talk to people, interact with them online that are facing really similar challenges to you. So check those out on our website. And then I really, really encourage you guys to follow us on social media. They're just really great opportunities for community. It's a center for information, for treatment options. So follow us at trickstop.com. We have Facebook, Instagram, TikTok. We have X also. I can write that. But I wanted to, first of all, thank you all for joining me today. And definitely don't forget, if you want to sign up, you get a discount of $100 for your first month off of TrickStop. So use the promo code PROWEB100. If you have any questions technically about our program, technical questions, email support@trickstop.com. If you have maybe questions about the presentation or questions, maybe more personal ones or clinical ones, don't hesitate to email me, maya@helpingminds.com. But I'll go through the chat now. If there's any questions or comments, let's look at them together. Okay, so the first question was, sorry, did you say SSRIs do work well for trichotillomania? So I'm not going to say that they work well for trichotillomania. That's definitely not what I'm going to say. There's no currently FDA-approved medication specifically for trichotillomania. The gold standard of treatment is HRT, or habit reversal treatment, which it's a behavioral therapy. We provide this here at trickstop.com. But there is some evidence that SSRIs have helped with trichotillomania, and that is cited for one of the reasons why it's under OCRDs, or obsessive-compulsive related disorders. So there is some evidence for it, but it's not an FDA-approved medication for it specifically. Okay, you mentioned that 25% of trich sufferers can also have an addiction. Does a person with trich develop an addiction, or are they predisposed because they suffer from trich? Does one cause the other, or do they just coexist? That's such a good question, and I wish we had an answer to it. And it's just such a complicated, thing, right? Because we don't know, is it nature, is it nurture, is it both? From the research, it seems to be that it's both, that there is this underlying maybe predisposition to having an addiction and also trichotillomania, but we don't actually know. Could it also just be the environment? Could it be that the environment that people are in, that they also become addicted to, say, smoking? We don't know. So we don't know what causes the other, if it's an underlying factors. It could be a confluence of things, but really, really good questions. I think I answered it. Why is it that many people with BFRBs have addictions? I think also just another thing is that it's very just high in the population, right? Like we know trichotillomania is up to, I think, 4% of the population. It's a huge amount. I don't know what the percentage of addictions is. That's actually a good question. But it's a huge amount of people. So it's a lot more common than we think. So another question is, how is addiction treated? Addiction is treated differently from trichotillomania. So trichotillomania, the gold standard of treatment is HRT, habit reversal therapy or treatment. That's a form of cognitive behavioral CBT. Addiction has a lot of different ways to be treated. I'm not going to get into that now. If you want to know more about that, you can send me an email. But specifically in terms of trichotillomania treatment, it's definitely HRT, which is a form of CBT or cognitive behavioral therapy. That's the gold standard, which we provide here at Trickstop. Okay, somebody wrote, my wife has some severe hair pulling and trimming problem. She brings it to me 5 to 15 times per month. So give me 7+ hours of what we've been calling care cuts. Me measuring her hair both sides of the head to make sure it's the same length, and if it's not, I have to trim the offending side. Repeat for every hair layer, top and bottom. Very time consuming. She probably trimmed her hair for another 5 hours. want her to stop cutting her hair, and I want to stop cutting her hair as I think I'm enabling, but she gets angry if I don't help her. What to do? So if we talk about the idea of, remember we said emotional distress, functional impairment. So yeah, it does sound very, very time consuming. And that you said that she gets angry, right? So maybe there is an element of emotional distress there and dysfunction. So honestly, I would maybe talk to her about it, just not in an accusing way, but to say, I'm here for you, I want to help you. I saw this webinar about trichotillomania. You can maybe show her our YouTube channel or our website. Look at trickstop.com. The resources that I showed. Here, I can go back one slide. These are all for free. So before you even need to sign up, and again, here, you can follow trickstop.com. But again, you have a promo code for the first $100, the first month, $100 off. So maybe signing up, she could sign up. It could be very, very beneficial. The next question is, how long are people typically in treatment at Trickstop? Oh, great question. I also wish I had a very specific answer. It totally varies because some people spend a long time on each session, but we actually do see really, really good results within a few weeks, and then also even more results within a few months. So it's very individual, but you can always trust. You have the free, the $100 discount so for the first month, so you can always sign up, try it out, see how you like it, and then continue from there. How common is it for someone to practice compulsive hair pulling but not in emotional distress or dysfunction because of their behaviors? I suspect not common, but curious if you've seen this. So if they have compulsive hair pulling and it's not extreme emotional distress because of it, then it's not considered a disorder. People, it's I guess it's not common because it would typically cause the if it's repeated and it typically causes the emotional distress, like it typically goes together, but people can pull their hair and not have the emotional distress, and then maybe it's not considered a disorder. So remember, those are the key criteria. Another question, is there a medication to stop? So like I said, unfortunately, there is no FDA approved medication specifically for trichotillomania, but HRT, which is a form of cognitive behavioral therapy, is definitely the gold standard of treatment that helps, has research proves that it helps with managing trichotillomania symptoms. So definitely you can look into that. And definitely look on our website. I'm assuming this is connected to the earlier question about the wife. My wife has anxiety too, and over the years has been on a number of drugs from her psychiatrist, but she's not taking anything this last year. How to broach the topic with her to do HRT or CBT? Again, I think talking to her, saying that I'm really worried about you. I saw this webinar, I thought of you. And then maybe provide her with some of our resources. Like we have a whole webinar specifically about HRT and trichotillomania. Definitely, I would maybe just show her and see what she thinks, and not in an accusatory way, but in a way of, I love you, I want to support you. Let's work on this together. Next question is ADHD a cause? So it's not a cause, but there is comorbidity, and we have a webinar on that also. So definitely go check that out on our YouTube channel. Next question is, are there communities for people with tricks so we can talk to each other? Yes, there are. What a great question. Oops. Here, again, bringing that back. Look at our website, trickstop.com. Look at our Facebook groups, Instagram, TikTok. We have lots of communities. Definitely engage. Oh, and on our if you sign up for our program, we also have support groups, so up there too. Since trich sufferers try stopping again and again, do we know what the recurrence rate of symptoms are after completing HRT? What a great question. We don't know what the recurrence rate is, but relapse definitely, relapse prevention is built into our program because we know that it is very common. It is very common. I don't know the actual statistics, but relapse is common. And so we don't want people to be stressed about that because it happens and there's ways to deal with it. So basically in our program, we have specific ways of dealing, of approaching, of preparing for situations like that. But it is very common. Next question is face-to-face telehealth therapy available through TrichStop app? That's not the main program. Our main program is online text-based communication with the therapist, so you are one-on-one with them. It is possible to ask for video sessions. It is more expensive, but that's not the main program. It is available. I am 1 year free of hair pulling after pulling for 40 years. Although this is amazing, will I start it back up? Wow, first of all, congratulations. That's amazing. That is amazing. Will I start it back up? Again, somebody asked about relapse. It could happen, but it's also something that you don't need to be hard on yourself about. You could start again and you can stop again. And it could happen for one episode, and then you can notice it and use your tools in how to stop again. So I think if you worked with our TrichStop, we have really specific tools on how to deal with relapse prevention. Oh, interesting question. I mean, finding antihistamines help me stop pulling. Is there medical evidence? I don't know. Interesting though. I wonder if there is, but I'm not aware of any. But I'm happy that it helps you. I'm not being able to access the communities on the website or Facebook. I can't get past subscription paid screen on the website. Is there another way? So through our website, you can gain, there's a blog. You don't need to pay to access that. And on Facebook also, you don't need to pay. It's just through join the group. So look up trichstop.com on Facebook. And you definitely don't need to pay. Yeah, for the TrichStop Instagram, you look up at trichstop.com. I have it here on the website, on my slides, sorry. Next question is, why did I start pulling my hair the past 3 years after I stopped for 35 years? I keep shaving my hair to stop pulling my hair. So that's a great question. Again, we're talking about a lot of people have been talking about relapses. So it could be that maybe there's some underlying emotional issues that are going on. And in addition to in HRT, it's the gold standard, the thing that helps you do replacement behaviors, you try and reduce things in your environment, shaving your head. Yeah, that could reduce environmental triggers, reducing the hair, but maybe there are underlying things that are going on. And in our program, we also use not just HRT, we also use something called ACT, acceptance and commitment therapy, that we kind of use to attack the problem from a different angle. We look at the underlying emotional things that are going on that are causing you to pull as a way to deal with the anxiety and uncomfortable emotions. So maybe you're going through a stressful period. I love the support. People are supportive of each other here. Do we know the neuroscience behind BFRBs? Like what areas of the brain may be driving the behavior? We have full webinars all about this. There is a lot of research, but it's not very conclusive. I want to start with that. I actually did a webinar on this maybe a year ago. Wow, time flies. But look up on our YouTube channel. There definitely is a lot of neuro research about BFRBs and specific brain areas, but not a lot of conclusive evidence, unfortunately. Another question is, how did the previous person solve after 40 years of being pulling 55 years? It is, a lot of people talk about this as a lifelong struggle, but definitely, again, if you want to try signing up for our program, you have here, I'll go back to our promo code. You can get a discount for the first month off and try it. See how you feel after 1 month. People often find a reduction in symptoms after only a few weeks. So I don't know if it's stopping, but you could hopefully reduce your symptoms and maybe feel better. Oh, I think that somebody said they stopped the itchy scalp, maybe in terms of the histamine. Great. That sounds wonderful. I don't know about any medical research about that. Next question is, how do I explain best to my partner that I have this disorder? That's what a great question. We actually have a whole session all about this in our program. We do need to finish soon, but I think it's a big question. In terms of explaining to your partner. So first of all, I think it's about being open and honest, saying how much you could show them some of our resources that we have, explaining to them that it's a way that it's typically something that it's used to cope with difficult emotions, and that there's a lot of stigma, there's a lot of shame around it, and that you want to share it with them because you want their support and that they could help you with this journey, because that really is often family members, loved ones can be a really important ally in your treatment journey. So that's what we all often say here at Trichotillomania. So also, if you want to sign up for our program, we definitely talk to your therapist. We have a specific session all about this. And the last question is, how much is your treatment pounds per month? Okay, so I don't know about in pounds per month, but it's $260 US every 4 weeks. So I don't know what the conversion rate is, I'm sorry. But you can email us at support@trichotillomania.com and they will help you with that. Okay, we don't have time for any more questions, but I'm really happy you're all very engaged, and I hope that you learned something new. So have a great day, and thank you.